Thank you for being here. I'm Bill Green, CEO of Homestead Smart Health Plans. And I have the pleasure of introducing Governor Ed Rendell, who I first met when I was 11 years old on a street on Green Hill Road outside my Aunt and Uncle Tim's house, where they were having a fundraiser for him when he was first running for District Attorney of Philadelphia. I met Ed many times after that. For those of you that know Ed Rendell, you will be maybe surprised to learn that most of the time as a high schooler it was at a Dunkin' Donuts on Midvale Avenue while he was district attorney and I was sneaking out of class to get some chocolate donuts. He was always engaging from the time I was 11 to the time I was in high school, asked me about myself, treated me like a real person, seemed genuinely interested in me. Not my father, not my mother, other people, but talked to me. So when Ed ran for mayor in 1991, I took a semester off from college. I came and joined his campaign as a volunteer, and I wrote policy papers for Ed. And I've been very pleased so I get to thank Ed Rendell for doing what he did for the city of Philadelphia, for the Commonwealth of Pennsylvania. But for me, it's very personal because I've never had the chance to thank him publicly for the support he gave me when I first ran for city council in 2007, and for the kindness he showed me throughout my life from the time I was 11 years old. So thank you very much, Governor. Governor Ed Rendell.
Good morning, everyone. Thanks, Bill. Bill has fulfilled that confidence I showed in him. He was a great city councilman and stepped down from one facet of public life to help education. And the School Reform Commission did some very good things for education, which they didn't get credit for, and Bill was a driver of many of those things. I am real pleased to be here today to kick this off because healthcare costs and quality and accessibility have been an issue for me from the time I was mayor, particularly during my 8 years as governor. And even now as a private citizen, I continue to advocate for new ways of doing things in the healthcare delivery system. Our healthcare delivery system is obviously broken. We spend more money per capita on healthcare than any country in the world, and our outcomes rank us not even close to the top 10 in terms of overall health of our citizens. We have, for the richest country in the world, to have as many uninsured people as we have is a flat-out disgrace. For some people, contracting cancer is a death sentence, a flat-out disgrace. Your health care depends, and your health and your lifespan depends more on your zip code than anything else, a flat-out disgrace. So we've got to find ways to do things better, and that means reducing the costs of health care at the same time improving accessibility and the quality of health care. That seems like a big jump, but it's possible. I believe it is possible, and I believe we're here today to discuss some new and exciting initiatives which I think will help us reach those goals. I've known Homestead's founder and chairman, Tom Knox. I've known Tom since I ran for DA, and Tom was with me when I was mayor and headed up the Office of Management and Productivity, and also gave me advice during the time I was governor. And there is no one in Philadelphia who knows more about healthcare, who knows more about how government and the private sector can save money than Tom Knox. You're going to hear a lot about Tom's latest vehicle called reference-based pricing. Bill's going to explain it to you in a little bit. But reference-based pricing is already adopted by Montana and North Carolina for its own health plans. And North Carolina is projecting a 15% savings with no diminution in quality and increased accessibility. 15%. The state of Pennsylvania could save 15% on its health care, not just for its employees, but for prisoners, for a number of people that the state does under the Medicaid program. If we could cut our costs by 15%, it would be just a manna from heaven. So, welcome everyone. This is an important conference. I know all of you are very interested in hearing more about reference-based pricing. We're going to start with Neil, who I think will tell us a little bit of the perspective from business standpoint.
This is talking about the whole idea of improving healthcare really has to be a business imperative. That businesses need to drive change in the healthcare system. We'll talk about why and what they can actually do about that. So very quickly, as Governor Rendell mentioned, we know that healthcare costs keep rising. Healthcare is around a little short of 20% of the economy. That's good for Philadelphia, where a big piece of the economy is healthcare, but not necessarily good for employers, for citizens, and for the nation. So we need to address the fact that, as Governor Rendell said, we are spending a tremendous amount on healthcare, but when we look at national, international statistics, we see that the U.S. actually ranks very poorly in relation to other industrialized nations. Where we rank number one is on spending. We spend twice as much as any other country per capita. But when we look at outcomes like life expectancy at birth, infant mortality, we really don't rank well at all. Access to care, equity, on any of these dimensions that we look at, and we know we can do better. And this is despite the fact that providers care, that we all care, that employers care. It's just a question of, are we using the right tools and doing the right things to drive change? Why do employers care? Well, I think everybody knows employers are paying for the better part of healthcare in this country. Over 50% of Americans are getting their healthcare through employer-sponsored benefits. And the cost has continued to go up. This year wasn't as terrible as previous years, but when we look at healthcare inflation and we say, well, it was only a 4% increase this year, that's good. That's not good if you consider how much of our spending is really unnecessary, poor quality, unsafe, wasteful kind of care. We know when we look at healthcare costs that employers typically are looking at the direct cost of care. What did we spend on our health plan? There are a lot of less clearly visible or hidden costs that we need to consider from the employer perspective. First of all, we need to look not only at the silo of direct medical spending on health insurance, we also need to look at disability cost and workers' compensation, clearly related to the overall health of the workforce. We also need to think about indirect costs, lost productivity, both absence and presenteeism, being on the job but not performing the full day's work because of a health-related issue. What's interesting is there's been research that the Integrated Benefits Institute, based in San Francisco, did research on with CFOs and said, is indirect cost important to you? And CFOs almost universally said, yes, indirect cost is extremely important to our business operations. But despite that, when we talk to employers and say, are you measuring lost productivity? They say no. It's not something I'm being held accountable for. I don't necessarily know how to measure it. I don't believe in the validity of those measures, like self-reported information. So there's a lot we need to do to educate. And when we look at the total cost of ill health, it's really critical that we look at lost productivity as well as the direct spending. We also know from a bunch of recent studies that ill health translates to less engagement at the job, and that translates to poorer job performance and less customer satisfaction. American Express did a study of their hotline workers and found a correlation between ill health and customer satisfaction in dealing with those particular workers. And finally, health helps to drive retention, or ill health is an impediment to worker retention, and we all know there are costs associated with recruitment, training, etc. So lots of reasons why business has to take management of healthcare and of health and healthcare costs very seriously. Now, what's interesting about it is when you look at what is being spent on healthcare and what companies are investing in the management of that resource, it's really insufficient. And so typically in even large companies, it's a fairly small benefits team spending tens or hundreds of millions of dollars on healthcare and relying on just a few very capable people, but nonetheless, people who were pulled to the limits to get everything done. So what can employers actually do? Well, there's a whole range of strategies. You're going to hear a bit more later about a few of these different strategies. But one of the key things is we have to get better at driving transparency. Where else in anything we do in the supply chain in business do we not know what it's costing us? Do we not know the price? Do we not know what we're getting for that in terms of quality? So it's unacceptable. We have to drive more transparency. Value-based insurance design, we have to think of new ways of offering benefits, designing benefits, so that we're paying for high-value services and not paying for low-value services. And there are lots of different ways to do that. Reducing waste. Roughly 1/3 of our spending is viewed currently as waste. Unnecessary service, duplicative service, administrative waste. And we know we can do better there. And as the purchasers, we need to drive that change. Group purchasing. We have the ability to get discounts through the system by bringing our collective market power together. Some employers are participating in group purchasing collaboratives, others not. Driving direct contracting with providers. So we've come to rely too much on our health plans to do all the work for us. And there are opportunities for employers, particularly working in a group, to identify higher quality providers, steer business their way, and actually direct contract with them. And I've only got 5 minutes, so I'm really going through this stuff quickly and happy to talk to you more at greater length individually. Reforming payment. We all say we have to get away from fee-for-service payment, but what it's going to take for us to actually do that and start to look at bundled payments and other strategies for creating a higher efficiency system. Engaging consumers. Many employers are now offering these high deductible health plans, which put more skin in the game on the consumer. That's good in a way, but we have to give the consumers the information, the tools, the education to really make that work and not just to penalize the consumer. And finally, we have to take more responsibility for managing the population, not only the workforce, not only the dependents, but the broader population in which we all live, recruit, and serve as, in terms of their being our customers or clients. So, very quickly, our coalition brings businesses together to work on these kinds of value issues. And I'm happy to talk to anybody about what we do. We have currently 48 employer members in the region, representing around 1.5 million covered lives. And I greatly appreciate that these employers have got the vision to say, we need to collectively invest in making a change in the local market. One of the key things that we do is drive leapfrog reporting. How many of you are familiar with Leapfrog Group? Half and half. That's sort of actually better than the typical audience. So the Leapfrog Group is an employer-led national initiative to get hospitals to be transparent about quality and safety information. And when we started our coalition, only 3 hospitals were voluntarily reporting their information. Because of our efforts and our employers getting up in the faces of the hospitals and saying, we're your customers, we expect you to be transparent. We've driven that up to around 60% of the region's hospitals that are now reporting. And you can see on the right, there's this thing, the Leapfrog Hospital Safety Grade. Safety varies greatly across hospitals in this region. We have a bunch of C-rated hospitals, as well as a bunch of A-rated hospitals. So as a coalition, we do a lot of education for members, and we're happy to share any of these tools with you. We're also part of a national group, the National Alliance of Healthcare Purchaser Coalitions. Groups like ours, trying to drive change, learn from each other at the national level and bring innovations back to our local markets. One of the big things we'll be working on the next year is implementing the Choosing Wisely campaign to further drive waste reduction. How many of you have heard of Choosing Wisely? Okay, a small handful, and most of them are members of mine who've been at one of my conferences. So Choosing Wisely, American Board of Internal Medicine Foundation, recognized there's a lot of waste in healthcare, asked physicians, specialty groups, to identify what are the things that you do that add no value to healthcare. And they had no problem coming up with lists of 5 to 10 things that they said, we do this, we bill for it, it doesn't change the diagnosis, doesn't change the treatment plan, doesn't do anything. So if we know we can eliminate 35% of waste, that's a major accomplishment. And even if we can accomplish a small fraction of that, we'll have gotten somewhere. So the Washington Health Alliance used a calculator that drives off of Choosing Wisely, and you can see here in this pie chart how much of the spending in the Washington state was actually attributable to wasteful care. There's a lot of transformation going on. You're going to hear about some of the innovations from Homestead. Just to point out, there are other national groups as well as the regional coalitions trying to drive change. The Health Transformation Alliance, a bunch of big employers have gotten together. They're starting with group purchasing of pharmacy services, but they're really looking at now, how can we go market to market and start to drive change? As the customers, as the purchasers, we are going to drive the cart, not the health plans, not the providers. And finally, we've all heard in the headlines about Amazon, Berkshire Hathaway, Chase, and to be determined what they do. But I think it's sort of symbolic of the fact employers are starting to realize it's unsustainable. We have to do things differently. We have to be disruptive. And we'll all be very interested to see what Amazon actually does there. So there's my contact information. Happy to follow up with any of you individually.
Good morning, everyone. So I'm Roy Schwartz. I'm here from Penn Medicine. Hopefully you've all heard of Penn Medicine. We're the health system and medical school associated with the University of Pennsylvania. I'm here to talk about innovations in healthcare. Typically, when Penn Medicine sends someone up to do that, it's one of our world-renowned physicians or scientists talking about curing cancer and coming up with all sorts of innovative treatments and cutting-edge therapies. I don't do any of that. I'm responsible for the partnerships and relationships with the insurers in the market. So I'm going to talk about some of the innovations that Penn Medicine's involved in that doesn't get a lot of headlines. You don't see it in major medical journals, but rather talking about how we are organizing, reorganizing, and changing ourselves to meet some of the challenges that Neil was just talking about. Again, if you don't know Penn Medicine, we represent 6 acute care hospitals from Lancaster to Princeton, New Jersey, and a lot of concentration, obviously, in the Philadelphia region. Thousands of specialists and primary care physicians employed by our system, and I guess what I would describe is that there's 3 elements to the strategy that we have towards bringing value to specifically to the employer community as they think about costs for covering their employees. One relates to how we've organized ourselves geographically and physically, the IT infrastructure that we've put together, and the leveraging of our diagnostic and treatment philosophy. So I'm going to go into all 3 of those and how they work together. I'll start with the where we started, which was with the IT investment. One thing that we recognized early on, 10 years ago, was that all of the value-based population health focus on integrated care, coordinated care, was not going to be couldn't be accomplished without an integrated health record, electronic health record that spanned the entire system. And so we've invested and at this point are somewhere around 99% complete with the integration of an electronic health record that spans our entire system. So what that means is regardless of where you're accessing care within the Penn system, in a community physician practice, in one of our tertiary quaternary hospitals, whether it's with a home care nurse, the electronic health record that you, the patient, as well as the provider has access to, is the full, rich electronic health record for the entire system. And that is a key building block for being able to integrate care and improve the coordination of care and drive efficiency in the system. So that was one. Second thing we did was realize that simply being a sort of an ivory tower in University City is not going to be what it takes to drive down healthcare costs. And so we very intentionally grew our health system to include some lower cost community hospitals and built out community multi-specialty centers, Radnor, Cherry Hill, Valley Forge, a number of them around the region, where you can both access the expertise of a faculty specialty physician, as well as have access to treatment in the community and in a lower cost setting than coming downtown for everything. So that was a second building block. The third was the idea that our greatest asset is our expertise in our within our employee base, our physicians, our technologists, our nurses. And so the ability to leverage their expertise anywhere you might access care at Penn. Neil was talking about the sort of the unmeasured advantages of avoiding absenteeism, of reducing sick days, those sorts of things. Well, our ability to diagnose more quickly, more effectively, more accurately, more quickly get a patient to the correct treatment, or identifying the conservative treatment that they don't need. They don't necessarily need to have surgery. They don't necessarily need to have the most expensive service. Our ability to identify that is something that we have distributed throughout our entire system. So literally go back to those other building blocks, the ability to work into our electronic health record the order sets, the pathways, the clinical pathways that allow us to take the expertise of our faculty and bring it out to the community has been something that is appreciably increased the efficiency and lowered the cost of care. So that's sort of that three-pronged approach. So what good is that if patients are going to fragment their care among multiple systems and you lose that? So we're also very significantly investing in, again, another concept that Neil touched on, value-based models. Value-based models, not just of payment, but value-based models of care. And so that means, value-based means a lot of different things to a lot of different people. What I'm talking about mostly is the idea that you don't focus simply on one step of the medical process, but you're looking at the totality of the patient, the total cost of the care of the patient, the total range of services they might be getting over an extended period of time. Penn Medicine is very involved in a number of programs. Bundled payments is one that Neil mentioned, where rather than expecting payment on every step of a process, we look for payment in the entirety of a service and then look to drive down cost, drive up efficiency, improve outcomes. We've done it with bundled care. We've done it with guaranteeing readmissions, so meaning we're going to take on the risk, the financial risk of readmissions. There are a number of different ways that we've done that. So I guess in summary, what I'm getting at is that in addition to some of the groundbreaking work that we do, often can be expensive, the talking about engineered immunotherapies and all kinds of great stuff we do, we're also focused on how to take care of the population in a more effective, cost-effective, efficient way with better outcomes. We've also begun to partner with the insurer community and to a lesser degree, but here we are today, to partner directly with the employer community. And we'll talk a little bit about the Homestead Plan, I think, a little later, where Penn is I think, a pretty critical partner in helping to drive down costs within that model. But we do it with other payers in the market as well, where we're really focused on driving down costs without sacrificing quality and taking full advantage of the advanced diagnostic and therapeutic approaches that we have.
Governor Rendell talked a little bit about what we do, but I'm excited to tell you more. Healthcare economics is an oxymoron. Essentially, regular economic principles don't apply when it comes to healthcare, $1 trillion segment of the U.S. economy. The payer is not the person who is choosing to get the service. That's a large part of the problem. There's also incentives over regulation. I'll talk about the minimum loss ratio and the perverse incentives created for the major carriers. And then also hospital systems have basically inflated list prices that are arbitrary, bear no relation to the provider's cost at all, or a fair profit. So that's called the charge master. I'll get into that in a second. So there's a great video that will explain this, which we're not going to run today for the sake of time, but it is called, if you just Google Adam Ruins Everything Healthcare, it explains a lot about the pricing mechanisms in hospitals. So here's the problem. increasing healthcare costs year over year. This results in cost shifting, so employers have increasing healthcare costs. They try to reduce that cost year after year by having the increasing deductibles and coinsurance for their employees. So right now the situation every year upon renewal is lose-lose. The employers pay more and the employees pay more. We are working to change that. So I talked about the charge master. Essentially, they're exorbitant. They're 400 to 700, sometimes 1,400% of Medicare. 1 to 3% of patients actually pay them. And charge master prices drive up the cost of healthcare for everyone, including the insured. There's a professor at Lehigh University who teaches law and business named George Nation, who's written a bunch of great articles on this topic. Also, we all know hospital costs are rising much higher than inflation. They were 72% of Medicare in 91, 2011, 343%, and today they're 450, 500% on average across the country. Also, you can have a $7,000 procedure at one hospital in town, and that procedure is going to cost $60,000 at another hospital in town. Here's an example of joint replacement pricing across the country. What is missing? What is missing is transparent pricing, and we'll get into that in a few minutes. So when I talked about incentives and overregulation, one of the unintended consequences of the ACA is something called the minimum loss ratio. That says that the major carriers must pay 80 to 85% of their premium dollars to healthcare providers. It makes sense in that I'm sure Congress and the President were thinking, well, if you have to spend it on premium dollars, then you're going to have the most efficient healthcare possible. The problem is that once you've taken that 15 or 20%, reduced your administrative costs as much as possible, your profit is the balance. So the only way to increase profits quarter over quarter and year over year is to increase the amount you pay for healthcare every single year. And that's why most public companies that are health insurers stock is up 1,000% in the last 10 years. So there's a perverse incentive in the marketplace. So in other words, if an insurer could pay $8,000 for a procedure instead of $10,000 for a procedure, or for many procedures, to use that negotiating power would cause them to have to give money back to their fully insured members, which you may have read some insurers had to do this year because they didn't get it quite right. So also interesting, for CFOs, as we go around talking to them across the city, we ask them what their first largest cost is. Obviously payroll, usually their second largest cost is usually healthcare benefits. And I say to them, well, what other expense do you have like that where you haven't negotiated your prices directly with the person you're purchasing the services from? And there's nothing else in their business where they allow that to happen. But instead, they allow these intermediaries called insurance companies, health insurance companies, to negotiate prices across the country, and this is a result. So those companies are negotiating prices that benefit them, not necessarily self-insured or employer groups, or even their fully insured. So here's an example of an MRI. If you walked in off the street, it would be $938. The insurance cost was $5,265, and patient responsibility is $2,756. There's an office procedure, $580 versus $1,850, with the insured having to pay $1,850. So there's lots of articles about this. This is just one person, Gene Pinder, and Clear Health Costs did a study of this kind of situation. So what do the insurance carriers offer? They don't improve quality. They don't reduce cost. So what do they advertise? They advertise access. You'll see the phrase around town, most doctors. But that doesn't improve outcomes. So what we do to solve this problem is called reference-based pricing. So we pay providers directly on behalf of employers, cutting out the major carrier middleman. We use a reimbursement technology or reimbursement methodology that is clear and transparent. So that means we pay a percentage, we pay Medicare plus a fair markup, or we pay the hospital's actual cost as reported to CMS, the Center for Medicaid and Medicare Services, plus a fair markup, whichever is greater. And I'll get into that. So we don't work from a top-down approach, charge master at 700% of Medicare. We look at government data to determine what is a fair reimbursement to the provider for the cost. So we take a bottom-up approach that increases transparency, because we're all across the country have a baseline. We know what Medicare is. We know what the hospital's actual cost for the service is, because they're required to report it to the government. This leads to lower unit cost, which is attractive to both employers and employees. And it allows us to fire traditional carriers and do the things that will change healthcare in a transformational way, because lowering unit cost alone will not do that. If you lower the unit cost, that doesn't improve outcomes, as Neil and Roy were focused on. And providers will adjust. As Neil pointed out, with these 35% unnecessary procedures, they'll adjust by providing more services per visit in order to make sure their revenue stays the same. So what's reference-based pricing about? Yes, lower unit cost right now, but it's really about firing the carrier. And so this is what reference-based pricing allows: disruptive innovation. And Roy talked about that in terms of direct contracting between employers and employees. And so we have a contract with Penn Medicine, and employers can access that, paying us no fee. They get our direct pricing with Penn Medicine. This allows for shared risk, warranty, as Roy discussed, bundled payments, direct primary care. So the company doctor is coming back in the next 5 or 10 years, where employees are going to be told, this is your primary care physician, this is where you go. If you go there, you have no deductible, no coinsurance. That person is going to direct your care with specialists, with hospitals and providers. True disease management. So by that I mean the insurers will say that they have disease management, but they have a disincentive to reduce the amount that they are paying to providers. So it is not very effective. Mandatory second opinions, which you can't have with most insurance plans, and opioid prevention and other innovations. And that is the true power of a reference-based pricing approach. So direct contracting, I've discussed this, and the key here, I think, the key takeaway here is that this approach will improve outcomes for employees, keep people in work more, increase the productivity of your workforce, save you money, and save your employees money. So we have one employee who has a slice offering, which means half their employees are on a major carrier and half their employees are on our reference-based pricing plan. The employer saved 20 to 25% on their cost, but the employee, because we're reimbursing at a fair and the fair price, and that there's a lower employee contribution because our plan costs less to the employer, actually saved $1,800. So this creates a true win-win, where the employers no longer have to shift increasing costs over to employees. We're very proud of our contract with Penn Medicine. Let's see where we are here. Okay, so this is why we pay the greater of cost or Medicare. If you look at items 2 and 6 on this chart, next slide, item 2, the actual cost plus 20%, as an example, would be $21,000. It would be unfair to pay the provider Medicare plus 25 because their cost is far less, at $7,150. Most people who say they do reference-based pricing in the market today only pay Medicare plus, not Medicare or cost to charge whichever is greater. So we believe this methodology is fairest to providers and to employers. So here's a couple of case studies I'll go through real quick. You can see the information up there. We replaced a major carrier at a company with 250 employees in Montgomery County. They're a food processor. This was an 8-month figure. They saved 36%. The full year is now in, and they saved 55%. They have $1 million in their claim fund at the end of the year, which is significant for a company of this size, and don't have to contribute to healthcare again until that $1 million is spent down. The next company is a manufacturer in the middle of PA, the last surviving subsidiary of Bethlehem Steel. They were having trouble with foreign competition. They needed to save money. If you look at this, they have negative trend. They were spending $1,271 4 years ago. They spent $921 per employee. No change in plan design, exactly the same plan design. In this case, we have true medical management with one of our partners, HCS, out of Columbia, Maryland. There is direct primary care contract for the employees, and there is a direct contract with a local hospital system. Also, we have a fully transparent PBM and RX. Savings can be significant when you combine all those things together, which is why we're excited about our contract with Penn Medicine and what it will enable. So, bottom line, with us, there's no network, although we'll drive you to people we have contracts with, like Penn, with no deductibles and no co-insurance, and having them exist outside of that market relationship. The one thing you'll hear about preference-based pricing plans is what if a provider doesn't accept it? Employees can occasionally get balance billed. It is a little bit more work for employers, but you're truly transforming the relationship your employees have with healthcare providers. They're going to be healthier, have better outcomes, spend less money, and so will you. So traditional plans provide absolutely no protection against balance bills. About 2 to 4% of people go out of network on traditional carrier plans. And the employer, they get their $20,000 bill, they have 40% co-insurance for out of network, the employee has to pay $8,000, the employer does nothing for them. Under our plans, it's about the same percentage, 2 to 4%, end up with a balanced bill. And the difference is our company provides a full legal defense for that member, and they never go out of pocket.
Well, let me give you, first of all, a brief introduction to who Woods is. That we're a fairly old and established organization, and we're also a lot different than many might remember us. We're based in Langhorne, Pennsylvania, where we have a large campus. But overall, we have about 200 different programs located in Pennsylvania and New Jersey. We serve about 12,000 individuals, and we're focused on population health management, which means for this incredibly fragile population, we are responsible for their care. We are establishing ourselves as a patient-centered medical home, and we are changing a lot of the way we deliver service, and I'm going to be going through that. In aggregate, we're about $330 million in revenue, and we have about 5,000 employees, including our latest affiliate, Legacy, that's coming on board. So why don't we go over just a quick look at a continuum of care. That we do have a broad range of services that we provide for the individuals that we serve who have behavioral challenges, developmental disabilities, acquired traumatic brain injuries, and beyond. Behavioral health is definitely an area of growth for us. We do that in the community. We do that a little bit at home, and we also do that in campus-based residential settings. We also operate 5 schools in New Jersey and Pennsylvania for children that have disabilities. Just a quick look at who our affiliates are. Legacy, as I mentioned, is our newest addition. Allies is a group home provider in New Jersey. Archway is a large school and residential operator. And George Richards, our CEO, is sitting in the audience here. And Bryan's House, Woods Community at Bryan's House, offers group home or waiver homes to Circle in Pennsylvania. And then Tabor is focused on child welfare, which I didn't mention, a lot of foster care services. And Tabor operates one of the CUAs in the city of Philadelphia and has been growing its foster care services. Okay. We've been up to a lot. Overall, we have a new leadership team that's in place. Our strategic focus, as mentioned, is much more on population health. A lot of improvement in services. We're working hard to increase our employee engagement, and given the way the market is going right now for talent, this is really important. Turnover for our type of employees can be very high, and the more we can do to retain employees in terms of making jobs interesting, fulfilling, as well paid as possible with good benefits is absolutely crucial to our success. We are working on sharing infrastructure and services throughout our organization, and then also thought leadership. Tina Hansen-Turton, our CEO, has brought an incredibly refreshing view towards how we approach the services that we provide. Going on to the next page, I am not going to read through all the stuff on this page. You can read that at your leisure if you wish, but
You've accomplished a lot.
Or wait, I'm the CFO. Holy Christmas, that must have cost a lot of money. A couple of highlights in there. We've established a new medical center to serve our individuals, as well as to provide health care to our employees, which is something that you're hearing about doctors on site. We have new clinical programs, new affiliation, completely done a lot of our benefits. Retirement, we had a defined benefit plan that we replaced with a defined contribution plan. We're offering education degrees, associates and master's programs on campus, and a whole bunch of new systems, a new electronic health record, electronic medical record, a new payroll and HRIS system, and a general ledger system. But there's more, and so moving on to the next page, we're not finished. We're expanding in Pennsylvania, as well as New York and New Jersey, because there's a lot of demand for the specialized services for the most challenging individuals that we serve. We're looking into options for an on-site pharmacy and how we can provide better service, growth in behavioral health, customer service that we provide our funders, the families of those we care for, as well as making sure that the quality of care for the individuals we serve in different ways is as good as it can be. And as mentioned, a lot of integration in common systems and things like purchasing. Okay. This is a quick look at what we see going on at a national level in the benefits area. Pharmacy is absolutely huge, and that's something we've done a lot of work on. Costs and transparency are real weaknesses in this area. The costs are just exploding compared to healthcare in general. Pharmacy costs have been going up in double digits, and I think this year the trend is only 12% as a rate of increase. And so the name of the game here is either transparency or it's rebating, which again is an incentive, as Bill mentioned, for more spending, because the interests with the pharmacy benefit managers are not always aligned. However, there are a lot of other things like employee well-being looked at holistically. That is a big area, and then behavioral health. It's a tough area even for employees. Going on to our employee benefits, I mentioned we have new degree cohort programs on campus. We have tuition reimbursement. We also have loan reimbursement, which is a new program for us. And that's important because where we do get people who are already credentialed, we want to make sure that we're valuing that resource. We are increasing our investment in HR to make sure we have the best benefits specialists possible, because the world of benefits is becoming more complex. Medical center, and then much better retirement benefits. We are working on career paths, which are very important for us to make sure that if we hire someone, we want to have woods for life in a way that you could say for our employees as well as for those that we serve, to have career ladders in place. And that starts with our direct support professionals. We're also heavily involved in what we're calling social innovation labs, which is a way that employees can engage and bring their own ideas, their own program ideas or business ideas, and we're making investment in those. We are working on on talent attraction, including diversity initiatives, as well as sharing our people across different organizations. Turning over to the benefits area for insurance, we are a larger employer than these, but what I wanted to show you with this chart is that self-insurance generally is increasing. And this is really important because this is changing the way that employers relate to providers. Because as Bill mentioned, if you're a fully funded employer, life can be kind of hard. You don't have good access to information. And it's kind of, this is what it is, and you can pay, and you can find a way to pay for it out of your profits or by sticking it to your employees. We can't afford to do that because of our margins, and we don't want to do that to our employees because for many employers, any sort of a pay raise gets taken out by increases in benefits cost. And we've been self-funded for a number of years, but the trend, I think, is notable to see that this says that more disruption is on the way, because once employers actually have the flexibility where they're not the same kind of mandates that ACA creates or the states create, there's a lot more flexibility in what we do. Just turning over to one more. Yeah. Reference-based pricing is relatively new. We are, I don't know, Bill, you can give an answer on this, around Philadelphia. We are, I think, either the only or the only not-for-profit out there.
I don't know other people's customers. We're certainly probably the largest player in the market that's using reference-based pricing, and probably, definitely the largest not-for-profit.
So this is new, and this is something that it has given us the flexibility to look in a different direction. Overall, that we've been self-funded, and we've gone through a traditional insurance company as our TPA for a number of years. And that's been okay, and we definitely saved a fair amount of money from that. The challenge is that the incentives to create the cost savings that we're looking for with good service, we find that we want to do more and we need more. All of the things that we're doing to change within Woods and our affiliates are costing us a lot of money. We estimate that around $6 million. And we have to find a way to cover those costs. And so reference-based pricing from a pure dollars and cents basis is very important for us. We wanted to be able to move to more of a population health focus for our employees as well, offer very good care with low copays or no copays, and have an open network. And reference-based pricing gave us a way to do that. Overall, as an employer, we found that for the employees that we moved into reference-based pricing, we have achieved pretty significant savings. That instead of flattening the cost curve, we pushed it down, and we're at about 20 to 25% savings. So that is a big deal for us overall, and we're using those savings to avoid increases in cost to our employees and also to fund our transformation. It is a different way, though, of providing coverage, and employee education is absolutely crucial because it's not like going through an HMO or a traditional PPO. And so our partnership with our HR team has been crucial. And having that ability to hold our employees' hands and explain that if a balance bill does come, what do you do? How do you handle it? We've got your back. That's been very important. And also to sell this, because everybody knows the big old names in insurance, and a new brand is something that's new, not only to our employees, but also to a lot of the providers out there. So education has been crucial. Partnership with Homestead and Index has also been very important, that it's not the traditional vendor relationship, and our ability to speak with members of the team at Homestead and Index when there are issues, or to talk about how we communicate and how we work with particular providers even, is very important, and that's given us a lot of flexibility. I think that our interests are aligned in general with Index, and that's important because if we have transparency, we understand what motivates Bill and his team, and it's the same as ours. That gives us a much higher level of comfort. The savings are good. There are challenges that we have had balanced bills, not a huge number. Most hospitals and other facilities have been fine. The actual providers, the doctors and specialists, that's not been an issue at all. There are one or two hospitals, though, that have been difficult to work with, and that is something that's just part of working through this, because there is a lot of resistance. And when Bill talks about the difference in pricing, that what we've seen for our employees is that Medicare might be 17% of the charge master. So a procedure that would cost, just to use round numbers, $17,000, a bill gets presented for $100,000, which is just ridiculous. And that's generally happened because insurance companies had said, we want a big discount, and the hospital said, okay, how much do you want? And then they've just raised their prices, and it's all been okay. And the employer ends up paying the difference. And what we're doing is changing the way that works. And for one or two hospitals, we're still working that out, but in general, it's been a very positive experience, and we think we'll get that taken care of soon. So just to wrap up with what's next, we are expanding. We started with a pilot where we had about 500 lives insured last year. And for our current open enrollment, we've expanded this to our affiliates, and we've also changed our plan design for our other non-index option, which is attractive, but not nearly as attractive here. And so the switches we're seeing look positive right now. Education will continue. That's both for our employees as well as at the provider levels. We get more providers to understand index and how it works. We have great data that we can analyze to see what trends are, and that's going to be important for us. Major disease management or sicknesses and catching that early is key. And I think as well, we're going to be doing a lot more with providers, and this is something that you're hearing a lot about, for what is the cost relative to the quality. And that could include direct contracting with specific facilities, where we can actually narrow a network and get a better result that's mutually beneficial.